Welcome to the Pharmacy Podcast Show. You are listening to the first and only podcast dedicated to the business of pharmacy. Hear from independent pharmacy owners, leading entrepreneurs, political strategists, healthcare technology trends, career coaching, interviews about our pharmacy industry, and more. Be sure to subscribe to the show via iTunes and leave us a voice comment from our contact section on the website. You can find all of our episodes at pharmacypodcast.com.
Hi, this is Dr. Lisa Dragic, a current PGY1 pharmacy resident at the Stratton VA Medical Center, and in a few weeks I will be a PGY2 in Arkansas for pain and palliative care, and you are listening to the Pharmacy Podcast Show.
Hey, welcome back to the Pharmacy Podcast Show. You know, I always enjoy having back previous guests on the show. And on April 15th, 2016, which has gone by so quickly, we did a show that was titled, Do Opioid Prescribing Guidelines Use Pseudoscience? And we had the one and only Dr. Jeffrey Fudin on the show talking about this, how opioid prescribing guidelines use pseudoscience and how the myths that are there impact patient care, and or I should say lack than better patient care. But I'm so excited to have back Dr. Jeffrey Fudin, and also accompanying him, somebody who I've been in touch with through the Pennsylvania Pharmacists Association, as well as Twitter, as well as the internet, meeting her in person at a conference probably 2 or 3 years ago. Time goes by so fast. Dr. Lisa Dragic, welcome to the Pharmacy Podcast, both of you.
Thank you.
Thank you.
So I want to start off with you, Dr. Fudin. First of all, welcome back to the show. A lot has taken place. I see articles that you're forwarding, as well as panels that you've been sitting on. My job in my world has changed since you've been on the show, where I'm now part of the new season addiction recovery team as Director of Business Development and Strategy. I can't tell you how my eyes have been opened even wider to this issue, but just to set the table, give the listeners, just in case they weren't able to listen to the show from April of 2016, a little bit about yourself and your mission in place. And also, I'm going to be directing them to paindr.com. That's paindoctor.com. Tell them a little bit about yourself, Dr. Fudin.
Great. Well, Todd, thanks for having me back. It's always great being part of the show. So I spent about 3 decades working at the Stratton VA in Albany, New York. I actually retired this past May, but I remain on as a without compensation employee, aka a volunteer, and continue to run the residency program here. Have a number of academic affiliations, and a lot of my time now is actually spent developing various software applications to help pharmacists and prescribing clinicians improve opioid safety. So we have a number of those. The company is called Remitigate, Remitigate, and it can be found at remitigate.com. And again, there are tools that we've developed that pharmacists can use, which we can talk about a bit later. You asked me how things have changed. Or maybe to give a short review. So the last time we spoke, I think the focus was on some of the pseudoscience, as you mentioned, around opioid prescribing guidelines, but more specifically about creating guidelines around morphine daily equivalents. And as you know, we published an article in the Journal of Pain Research talking about that with Dr. Michael Chapman and Dr. Jacqueline Pratt-Clary. And we point out in that article that simply looking at morphine equivalents without considering the genetic variability in various populations is not a good thing, because obviously many of the opioids are metabolized to more active metabolites, and also inactive or less active metabolites, and depending on your phenotype, you can be making a whole lot of more potent opioid, or not converting the patient to an active opioid, which would mean that a high dose in one patient is equivalent to a low dose in another patient. That, of course, does not account for weight. A 20 milligram dose of oxycodone in a 150-pound man is not the same as a 20 milligram dose of oxycodone in a 300-pound man. So that that's another difference. And then there are other issues as well. The various opioid receptors, MTHFR, which is necessary in order for non-opioids and opioids to work, but specifically has an effect on SNRIs. So there are a lot of factors that are really missing, and even if we ignore those factors, there's also drug interactions. So, for example, if you have a patient on an SSRI or an SNRI that's a 2D6 inhibitor, and you're depending on oxycodone to be metabolized to oxymorphone by 2D6, and that's going to be a problem. All right, so there are a number of issues, and that's the reason why I believe that a lot of this is pseudoscience.
I was fascinated by pharmacogenomics and the study of how drugs break down in one person differently than another based on their DNA, and how opioids obviously play right into that in breaking down those specific pain medications and or anything under that class. I find it very relevant that we have to continue to talk about this. This is why I'm having you back on the show. 30,000 or nearly 30,000 deaths per year because of overdoses on opioids. This is a serious national problem. And as someone who spends their day after day and week after week working with centers throughout the country to do nothing but put patients on tight regimen treatment programs to help them get off of being addicted to opioids, it's been eye-opening but continuously mind-boggling to me that there isn't more of a consorted collaboration between health system, pharmacist, physician, counselor to really gravitate towards a continuum of care for the disease state of what is opioid addiction. So what I'm excited about is that you continue to press this. You're placing technology also in the forefront with some of the calculators that you've designed and that you've put together, which I'm excited about. And you'll be actually, Pharmacy Podcast listeners, you'll be hearing more about this because we'll make sure that we tweet this out, put this on LinkedIn as well as through the Pharmacy Podcast Network. I want to kick it over to Dr. Dragic. If you could please give us kind of an overview of what you've been doing, and then I have some questions for you of some of your studies that you've done recently.
Yeah, thanks so much for having me back on the show as well, Todd. Some of the things I've been working on this year, one of my research projects has to do with alcohol monitoring and patients on chronic opiate therapy. And for what we know, alcohol also plays a significant role in the overdose deaths that are involved with opioids. We know that it increases the risk for opioid-induced respiratory depression, as well as if patients are on, let's say, a long-acting opioid. It can cause what's called dose dumping. So that long-acting opioid will actually turn into a short-acting opioid. So my project was focused around looking at that because many of the guidelines do not have alcohol monitoring as part of the standard of care. So that's what I've been working on a little bit. And so far, we've seen in our patient population that we've been doing this on, we've been monitoring it through ethyl glucuronide and ethyl sulfate metabolites. And those are direct metabolites of alcohol consumption. So right now we found that approximately 9% of our patients are positive for the ethyl glucuronide results.
So that's something I would have never have considered. And when we start interviewing patients during intake to a program, there's questions that are always being asked, and I'm not even sure if alcohol is being asked as one of them, but I'm sure that plays the part. As we all know, when you start to drink, especially if it's intense, drinking, you start losing track of good decision making, and all of a sudden you could easily go back to a very bad habit that you're trying to break based on your opioid intake, even if it's a painkiller and or a mixture, which could be very dangerous mixing with alcohol. So that's absolutely fascinating. Lisa, I also invite you back, as well as Jeffrey, back to the show to give us more information on that research. And you can use the Pharmacy Podcast Network to push that information out as much as you want. Because once again, like I said, this is not only is it fascinating, but it's necessary with the tremendous epidemic that we're facing. In 1991 to 2013, the number of opioid prescriptions in the United States went from 76 million prescriptions to over 207 million prescriptions. So, rushing to prescribe anything opioid-driven, I know that we're finally seeing a stay in it, and it's starting to pull back a little bit, but in my opinion, it can't happen fast enough. It's a relief to me to hear the both of you doing such immense amounts of research on the topic, because it folds into many other things that will affect the community, families, people's jobs, people's lives per se. So kudos to both of you. Dr. Fudin, I'm wondering, tell us a little bit about the application that a pharmacist can use to identify very quickly and then leverage that information to suggesting a forward in therapy.
So one of the platforms that Remitigate, my company, has developed is an application called Naloxotel, which is web-based, so anybody can use it. And it's based on a validated linear regression analysis that was published by Barb Zedler. And actually, there's one in print now in Pain Medicine that shows it's 90% accurate. So it basically asks the pharmacist, just by putting a check mark, yes, no, things like, does the patient have a history of opioid abuse? Do they have schizophrenia? Do they have any pulmonary disease? Have they been admitted to the hospital in the last 6 months, in the ER in the last 6 months? Are they on extended release opioids? So several questions, just yes, no. It takes less than 2 minutes to fill it out. In the background, it calculates out the daily morphine equivalent. And then, boom, you get a very comprehensive progress note that says this patient's at 43% risk of having opioid-induced respiratory depression over the next 6 months. The following are criteria on which this was based. List those criteria. It will go on to actually pick up drug interactions based on the opioids that you put in. Then it will ask you if you want to give the patient naloxone. You select the product. If you select the most expensive of them, which is Ebzio, you'll get a drop down. You'll need to justify it. My caregiver does not have manual dexterity to give an intranasal dosage form, or the patient has chronic sinusitis. Then it will ask you who you counseled on a drop-down, caregiver, patient, or both, and how many minutes you spent. So after doing this, which again is about 2 minutes of input, you get an extremely comprehensive note that you can give to the patient. You can put in the chart, you can fax or electronically send over to the prescribing clinician. And this really doesn't even have to be done by a pharmacist. It can be done by an intern. And it really opens up a segue of conversation between the patient and the pharmacist, because when you present a document that shows the risk factors, then you can work with the patient and the prescribing clinicians to try to chip away at those risk factors that will bring their percent risk to a lower percent.
You also have done work in developing a mathematical equation in order to manage methadone, in using that for pain management, which is fascinating. It's something that I'm going to get to my own executive level team, because we try to partner with different pain management organizations throughout the country, the ones who are managing pain without opioids, of course, and in leveraging some of the technologies that are out there, that we know are out there, that are available to mitigate pain based on anything but leveraging opioids. So tell us a little bit about that as well.
So you're right. I'm feeling like you're stalking me here. You know a lot about me. You did your homework. So I did develop a formula several years ago. It's actually copyrighted as the Fudin factor. And the reason I developed it is because prior to that, conversion to methadone was based on, the original schematic was by Ripamonti in 1998. It was based on 38 cancer patients. And basically, that schematic said that if you're on 0 to 90 milligrams of morphine or its equivalent, then the conversion factor is 2.75 to 1. If you're between 90 and 300, then the conversion factor is 7.75 to 1. And if it's over 300, it's 12.25 to 1. So what that boils down to is the more opioid, morphine, or equivalent that you're on, the less methadone you need to replace it. So Aaron Rindy came along a couple of years later and had 5 data points where the conversion would change. And then Merck and Dante basically rounded those numbers up. So instead of 7.75, it was 8. So, there's no way the body knows that if you get to 1 milligram, all of a sudden you change the conversion. And so if you graph it out, it was a disaster. A lot of the online opioid calculators, they don't, the calculators don't know, it's just math. And so if you go in one direction, it will be an overdose. And if you go in another direction, it can be an underdose. So that's why I developed the equation, because it smooths out the curve at the most conservative points. I'll tell you what's really scary. I'm glad you brought this up, Todd. What's really scary is that recently the CDC released an online opioid calculator, and theirs most closely simulates Aaron Rindy's schematic, which is the most disastrous of all of them. Intuitively, you'd think that it was more accurate because it's 6 data points instead of 3, but actually it's less accurate. I think you probably know that I've tweeted out some of the CDC opioid calculator flaws with regard to methadone, because it's really, really dangerous. And I actually hope to meet with the CDC, because I've had some discussions with various federal agencies of how much of a disaster it is. And Lisa knows from her work with me that if we put a patient on methadone, we don't just make the conversion. We use that equation to give us kind of a target dose of where we're going, but we still do it slowly and carefully.
Can't there be some type of predictive analytic measurement in place, knowing that based on the patient's DNA, weight, other demographics per se, that you could say, based on other patients in the past that have gone through similar therapies, where we need to be, say, in 30, 60, 90, 6 months, 9 months, 12 months, in order to give pharmacists, addiction counselors, physicians, a better, tighter roadmap?
So if we did genetic testing, which pharmacists could be involved in, I think that would help us predict these things as methadone went up. So I know that Lisa knows the answer to this question since she trained with me. So one of the disasters with the cytochrome system with methadone would be what, Lisa?
The CYP2B6.
Right. So methadone. So one of the issues with methadone is not so much that methadone is a disastrous drug. I mean, it's a great drug, but you need to know what you're doing because it involves 6 CYP enzymes. But methadone is an enantiomer, and so it's got the R and S enantiomer, and the S enantiomer, as Lisa points out, depends on 2B6 to convert it to its inactive form. If you are genetically a poor 2B6 metabolizer, then you'll accumulate the S enantiomer, and that can cause tardissides and fatal ventricular tachycardia. So we can predict these things if we do genetic testing. We need to watch the QTC intervals in these patients. If a pharmacist is filling a prescription and they know that the patient is on, let's say, an atypical antipsychotic, and they're on methadone, and a prescription comes in for a quinolone, unfortunately, the pharmacist doesn't generally have this information available to them, but it would be worth a call to the prescribing clinician that's writing a quinolone, or that's writing, let's say, azithromycin or a new atypical antipsychotic, because there's a potentially a higher risk of tardissides because of effect on the QTC interval. And Lisa has seen a number of patients here with me where we've actually, in some cases, put an allergy in the chart because we don't want a patient to show up to the ER and end up getting an antibiotic that will potentially increase the QTC interval. I mean, that would be a disaster.
Oh, it's just fascinating. I tell you what, if we could package the tools in place that you're talking about and then hand those off to a pharmacist who is interested in doing the deep dive reviews, especially being able to go into their pharmacy management system and pick out patients that they know have been reoccurring opioid prescribed patients, then being able to flag that and then do a medication therapy management review with that patient in tandem with these tools, we could save lives. And I think this is so important. So I just want to continue to be your cheerleader, both of you, in making sure that I can echo boom some of this information out through the Pharmacy Podcast Network, because there are other pharmacists listening to this show that I think are going to have lots of follow-up questions. So we're going to make sure that we have information in the show notes in order to get a hold of both of you. But I'm absolutely just blown away at the research, the intense research that both of you have done. This is an extremely serious issue, but it's going beyond just the addicted patient. It's going into actually how to use these medications properly in order to have them do what they've always been intended to do. And part of that is, hey, Mr. or Ms. Patient, can you or can you not metabolize this as it was designed to be metabolized? So I'm absolutely, like I said, fascinated by this.
Thank you. And I know that when Dr. Dragic moves on to Arkansas, she's going to be doing a lot of pain management stuff and carrying the torch, as have many PGY2 pain and palliative care residents. And I'm looking forward to some of the fine work that she's already talking about doing before she even gets there.
So, Lisa, how do you say to a pharmacist listening that they can combine what we know about medication therapy management reviews and the world of addiction, the world of pain management, in order to take advantage of some of the payment opportunities for these pharmacists under the umbrella of what is MTM? What do you say to the listeners today to be able to fold this in nicely?
Yeah, so I think something really important that goes to, the addiction aspect and also pain management would be really like risk stratifying our patients. And we can use different tools such as the Reassured score, which sets the risk index for serious opiate overdose. And that actually utilizes one of Dr. Fudin's software, the Naloxotel. And, community pharmacies can use that to generate and identify patients who may be at increased risk for an opiate overdose. And there's other tools that pharmacists can use, like the SOAP and COM surveys. So these are basically just questionnaires that look at patients' potential risk for addiction and abuse. So those are some of the tools that they can utilize, and it will really open the door to have a conversation with the patient and allow the patients to really understand that there are certain risk factors that can increase their risk for overdose, like sleep apnea, if they have any like asthma, COPD, if they're on a long-acting opiate, if they're on a benzodiazepine. So I think that they can really utilize that in the community setting.
That's incredible. I just want to thank you both. And once again, it's an open invitation to interview and bring you on the show again because of how insightful and you really dig down into the crevices of these issues, the challenges that we have as healthcare providers. But I just want to thank you both for being back on the Pharmacy Podcast Show.
My pleasure.
Thanks so much.
We hope you enjoyed another episode of the Pharmacy Podcast Show. Be sure to subscribe to the show and send us a voice message with your ideas and comments from our contact section on the website. Did you know we develop digital health content to assist with business development and marketing efforts? Learn how we can help you drive more patients, physicians, and targeted leads to your website. Contact us today at pharmacypodcast.com.